It's wonderful to be here, and it's wonderful to be in a room full of other emergencistas. Did I get that right? I think I'm going to call myself an emergencista from now on, because emergency physician just sounds lame in comparison. I work in emergency departments, but I also work for Greater Sydney Area Helicopter Emergency Medical Service, or Greater Sydney EMS. And I'm going to talk about a particularly challenging trauma case that I was recently involved with to outline some of the ways that we do business. Any Australian has a slide demonstrating how big our country is. It's mandatory. And all this is here for is really to demonstrate that aeromedical systems in our country are fairly necessary to get patients from faraway places to big cities. Where I'm from is this bit, New South Wales. It's about 800,000 square kilometres, about 6 or 7 million people. There's 9 helicopter bases across the state. 2 of those are in Sydney, in the capital, and they cover a range of about 300 or 400 square kilometres from those bases, which actually soaks up the majority of the population, which is along the coast. And they're complemented by fixed-wing bases across the state, which soak up the rest of the population. The system that I work in is part of that system, Greater Sydney EMS, and there's 3 bases around the Sydney Basin where actually most of the people in the state live. And at Greater Sydney EMS, we do just under 10 missions a day across those 3 bases. 30% of those are pre-hospital, and the majority of those are trauma-related. So I'm going to speak about one of those cases. And for those cases, our team is basically made up of a doctor and a paramedic, both fairly highly trained, and we're going to talk about the training that's involved. I'm primarily a clinician, but the team that runs Greater Sydney Area EMS is actually made up of some fantastic individuals. And you'll probably recognise Cliff Reed on the left, who's our training director. He's been involved in SMAC and other things in the past. And these guys have really pushed through a lot of change to the way that we practice and train. So let's get on to the mission. We got a call at about 8:10 in the morning, just after the start of the shift. Always an awkward time. Still had a full bladder. Hadn't had my coffee. Wasn't ready. There were 2 motor vehicles involved in a major accident just south of our base, about 170 kilometres from the major trauma centre. So our base is actually a little bit closer than the major trauma centre, about 30 kilometres away. And we landed on the roadway and contacted the patient about 35 minutes after dispatch. So this is a closer look at the car. Fairly badly damaged, and this is the position of the patient within the car. And I guess what I've tried to represent here is just how he was sort of bent in half by the A-pillar, or the front part of that engine and dashboard. His legs and pelvis are just sort of disappearing into this mess of plastic and metal. But what this doesn't show is all the anxiety-provoking stimulus that was sort of associated with this. He was agitated, he was critically unwell, he was bleeding all over the place. There were bystanders who were anxious, and there were pre-hospital providers that were looking to our team to give some direction. This guy looked like he was in a great deal of trouble. And a lot of our training focuses on how to deal with that anxiety that these sort of scenes provoke. So in amongst, it was fairly chaotic, as often these scenes are. We got a fairly scattered handover, but essentially it was a high-speed motor vehicle accident. Our patient was the front seat passenger, and he was compressed by the A-pillar. He had multiple injuries, and he was really critically unwell. They could only feel a carotid pulse, and his GCS was 5, and he was agitated. Somehow, the team on the scene had managed to get an IV in, which was extremely helpful to us. And we actually had bystanders providing some manual inline stabilisation of his head and neck. And they were just starting to work out how they were going to get him out of this vehicle. So I turned to my paramedic and said, this guy's going to die if we don't get him out of this car right away. We can't wait for the 2 hours of modern artwork extrication, which the firemen like to do, bend the car this way and that way. We have to get this guy out. And so whilst we were organising that, we started a warmed blood cell transfusion, and we've got access to both pack cells and warming devices. And we literally just reefed him out. If we hadn't have done that, I think he would have died in the vehicle, and that's not a good outcome for him or for us. Ordinarily, I guess as many of you who work in the pre-hospital world will know, an extrication of this type could take at least 30 to 60 minutes. So that was time we just didn't have on this occasion. So now we're able to assess him in a bit more detail. His airway was patent but not protected. He had lacerations all around his mouth, but his face seemed stable. He was tachypneic. We couldn't record SATs because he was so badly perfused. And he still only had a centrally palpable pulse, so he's in real trouble. And there seemed to be a couple of very worrying and obvious sources of bleeding that we could see. He had a big hematoma across the centrum of his abdomen, and his legs were splayed, already had scrotal hematoma and blood at his meatus. So he was in real trouble, and some extremity injuries just to cap it off. So we had a multiply injured, critically unwell patient in hypovolemic shock. And in the next 20 minutes, we did 15 procedures. I'm just going to leave this slide up for a little bit just to let you absorb what was able to be achieved by a team of 2 + 2. And I don't think I'd be able to do this in my emergency department with a team of 10 because we don't train in the same way. And included in that was fairly intensive management strategies like RSI and ventilation, thoracostomies, and various types of fluid delivery. So we got him into the aircraft. We used that dead time to do procedures such as an EFAST, and an EFAST was positive on this occasion, both in the pelvis and in Morrison's. We travelled the 170 kilometres up to the trauma centre, and en route, I was able to talk to the trauma surgeon directly, and she agreed, yeah, let's get this guy directly to the operating theatre and let's have some blood waiting for him because there's nothing else that you can do, Mark. You're doing everything that you can do, and I need to get in there and do some damage control. So about 150 minutes after his injury, he was delivered to the operating theatre. And I went to get a coffee and a lie down. And the next day I rang up expecting him to be in the morgue, to be honest. But he'd made it through that first day after a lot of work had been done. And as you can see, he was terribly unwell. He went directly to have a damage control laparotomy. He was found to have massive bleeding from his pelvis, which was eventually stayed to some degree with a combination of packing and coiling. His colon was resected after being found to be perforated and ischemic. And he was just stable enough towards hour 2 for the anaesthetist to start an anaesthetic. So they really didn't have any blood pressure for those first couple of hours. He had lots of tests in the operating theatre, and he had injuries from top to bottom. So diffuse axonal injury of his brain, gross pelvic disruption, which you can see, disruption of his femur, of his forearm, and of his face. And during the first 72 hours, he had 5 further trips back to the operating theatre. His pelvis was repacked, iliac veins ligated, and his bony pelvis was eventually stabilised, as was his femur. I followed him up for a little while, and at day 70, he was still in ICU. He was just about to be released. You might have wondered what his brain was doing. Well, he was awake and alert enough to be throwing his colostomy bag at the nurses, so he was doing okay. He was just about ready to go to the rehab ward, and it's a remarkable case that I never expected to get past the first 24 hours. And I think if he'd come to my own institution, he wouldn't have made it that far. So how, in this environment, which is the back of our AW139 aircraft, can we do all this? Well, I think there's a number of things that are responsible for the way that we practice, and protocols and training are amongst those, and I'll talk a little bit about those. So protocols aren't always a dirty word, I've found. A lot of people would consider them a substitute for decision making, but I consider them an aid to unload my brain, which is already overstimulated. So if I've got a way of doing something that I don't have to think about, then that makes it easier for me to take in the whole picture and to deal with all this anxiety-provoking stimulus. And Greater Sydney HEMS has a number of trauma and other protocols, and a number of them were used on this particular occasion. So the other crucial part, and Cliff Reed has been instrumental behind us improving our training, is performance-based training. So training that focuses on what will actually happen to you when you're at the roadside. And he calls it training as you fight. And it's multimodal, takes in some theoretical stuff to begin with, and then masses of scenarios. So we start with excellent in-hospital providers, people who worked as anaesthetists, as intensivists, as emergency physicians, but they don't have any experience. So how do we get these guys and gals like Pablo and Laura up to speed so that in their first shift they might have to crack a chest or deal with someone as unstable as this? These guys have to hit the ground running, as we say. In order to reduce the time spent in the classroom, they actually start their training before they get to work, in the month or so before, with some flipped classroom, which we've already heard about during the conference. So a lot of the service protocols that they'll be using will be introduced in this fashion. There's quizzes, there's videos, podcasts to introduce those, and it saves time when they eventually start work. Then there's the formal induction course, which is for the registrars when they're starting, and also us older consultants. We have to do it from time to time to refresh our skill base. A particular part of this is actually the non-technical skills, so learning about how to master yourself, your team, and your environment, all of which can be terribly challenging. And I think in this particular case, the self-mastery to overcome all these external stresses was very important to me. Because as I've said, I wasn't really at my mental peak on this day. You know, I'd been planning a training mission, hadn't had my coffee, my bladder was full, I needed to go for a wee, and hadn't finished my morning checks. So by utilising some of these techniques, I was able to get my head in the game. And it was really critical on this occasion. As we were flying to the job, I was going through, talking myself up, saying, I can do this. I've done this before. I'm a part of a good team. I know the people I'm working with. I was visualising the procedures that I needed to do, the intubation, the thoracostomies. And I was remembering that I could offload some of this cognitive overload by using our checklists and our SOPs. So, once we've looked at dealing with stress, we create it for the registrars during the induction with incrementally increasing severity of simulations, with lots of stress exposure and inoculation and perturbation. We try to use live actors, like Marty here is one of our paramedics who's simulating being stabbed in the chest, and I've done this scenario and it was very off-putting. He's a very good actor.
He looks really blue.
And I think he died on me actually when I did this. We also try and use low-tech but high-fidelity devices like the iSimulate. I'm not involved with this company, but there are many that have this same type of technology where a control iPad controls a monitor iPad. And there's sound and there's vision to increase the fidelity of your scenarios. And it's still fairly low-tech. Patient's getting better there by the sound of it. Okay, and halfway through the week we do some specific skills training on pig and mannequin models for the really high stakes procedures that we might only do once in a career, like the clamshell thoracotomy, like the hysterotomy, escharotomies, and even burr holes if we go out to extremely remote places. The week concludes with an exam, which is team-based, and at the end of it there's fairly justifiable relief and a few beers usually. So to cement the advances that occur during this time, there's a rigid sort of process based around M&Ms and fortnightly scenarios and daily training. But critical to it is our clinical currency. So every doctor and paramedic has to do 3 and 6 monthly currencies to be able to work. They have to prove online and in scenarios that they're able to intubate patients and do other procedures as per our SOPs. So what does the future hold? Well, in a couple of years' time, there's going to be a super base built in Sydney, which will be the state training base, and it'll have a pool, which will allow us to do water rescue training. It'll have a flight simulator, a virtual reality training area, auditoriums and classrooms. And initially, the virtual reality will be limited to crew training, and it's adapted from the military. So this is one of our fellows practicing in a virtual reality environment with winch management. But eventually this will be rolled out into the medical scenario world. It's an extremely exciting prospect for us. So what have I drawn from all of this? Well, when I'm in a stressful workplace environment, like Timmy Cahill is here, I just have to remember my SOPs and just pass it to Cahill, basically. And remember my performance-based training. And then even if you're the Australian soccer team, you can score a goal against the champions of South America. And I'm going to leave this on for a bit just to remind you what happened. We did lose that game, but it was the highlight of the World Cup for me. And then we get frisky with a kangaroo. I don't think that's legal where I come from. So look, thank you very much. I've gone a little bit over time, so I'll stop there. Thank you for the organising committee, and thanks for your attention.